Thank you, sir, for giving me an opportunity here. So, if you look at the slide, the standard of care in the management of endophthalmitis happens to be antibiotics, intravitreal, to some extent the systemic, past vitrectomy, biopsy, and steroids. So, nowhere in this you find silicone oil as a standard of care, and why are we debating about it, especially in an attached retina? So I would like to extend the debate on these four subheadings. The first of which happens to be the influence by the type of the organisms and antibiotic susceptibility. So when you look at the type of infection causing endophthalmitis, we extensively studied and published 3 reports on what would be the common source of organisms we found in our subset of patients. And fortunately, most of these patients happens to be gram-positive organisms. And amongst the gram-positive organisms, coagulase negative staph happens to be the most commonest organism causing endophthalmitis, whether it's going to be post-operative or it's going to be post-traumatic. So we all know that outcomes of endophthalmitis caused by coagulase negative staph is one of the best outcomes we can ever get. So majority of the organisms, gram-positive, among them coagulase negative staph, they have very good outcomes. Why oil? So, and certainly the debate can extend to a small subset of patients where we have multi-drug resistance, and them among being the pseudomonas, but they form only 1.5% of our patients, what we have reported earlier. So, having understood the organisms, most of the organisms, if you look into the gram-positive, over 98% of them are sensitive to vancomycin. And there, if we have an antibiotic to which the organisms are primarily sensitive, why inject silicone oil? With that, I will move on to the second objective. We have to understand the pharmacokinetics of the antimicrobials in silicone oil filled eye. To be frank, we have even published a paper of how silicone oil possesses antimicrobial properties in vivo. And having said that, it doesn't mean that this could be used as a primary or the first line treatment in the antimicrobial cover of endophthalmitis. So we also have to understand the pharmacokinetics. We published this paper, but to the extent that we have no paper which says the pharmacokinetics of antibiotics in a silicone oil filled eye. We have no publications on that. And what happens is when we inject the antibiotics just after the fluid exchange happens, and then we inject the silicone oil, the antibiotics gets trapped between the oil and the fluid interface inferiorly. So there is a possibility that the organisms which get sequestered anteriorly tend to remain there, and these antibiotics would not find a place. Now, in case of persistence or even recurrence, like what Manish had mentioned, if an oil is already been filled, what is the concentration we are going to use? We know that it is going to be 1/4 or half concentration before injecting the oil. But within the oil, we are not sure whether it's going to be half, a quarter, or it's a full dose, and how long does it take to act and eliminate from inside the eye. With that, my third question is, does silicone oil prevent retinal detachment? So we know that the two most important causes of retinal detachment in a patient with endophthalmitis is extensive amount of vitrectomy, especially the ones where we are not able to see what's happening in the periphery, and the inflammatory milieu being so critical to create those peripheral breaks, which we may not be able to see on routine surgical procedure manipulations. And also understanding the fact that endophthalmitis are mainly caused in cases where the organisms have been highly virulent, like the gram-negative ones, where the higher chance of retinal detachment. So, but even when there is a condition of persistent endophthalmitis where there is the chance of oil being injected into the eye, so there is another problem. What we face is when the premacular bursa is not being able to remove, or when we have an ERM formation, there is a double layer ERM which forms whenever there is an infection in the eye with an oil. The top one is very similar to the perisilicon membrane, and the lower ones is very densely adherent to the macula, which can create sometimes can create a retinal break when you try to peel the membrane. And sometimes when we have to either sacrifice the lens or intraocular lens or a clear lens, or so we might create in one chamber, and we have problems of oil migrating into the anterior chamber, and it has its own set of problems. So how about the outcomes of silicone oil filled eye? And one of the important questions is, can it reduce the additional procedures? We know that about additional procedures are more common in patients who had virulent organisms, what is reported in EVS. the other published which has happened does not indicate that
Dr. Avinash, you'll have to wind up fast.
with silicone oil, the additional procedures can be reduced. So repeat procedures are associated with decreased outcome, and the visual outcome primarily depends on the type of the organism and not on the usage of silicone oil. Thank you very much.
Thank you, Dr. Avinash. Thank you, Dr. Manish. A quick word from Manish before Dr. Mahesh takes over. We're running short of time. We're just about 2-3 minutes left, I think.
Thank you, Avinash. Excellent, and I think your everything is backed by data, and I don't argue at all with the fact that not standard of care. It doesn't prevent detachment, like you said, but it contains, as I mentioned, it allows you time because there is a segment of patients who will come back with some sort of inferior fluid or detachment, which will be hidden in case you haven't put compartmentalized with oil. It takes time for you to diagnose, and by that time it's PVR, and I'm sure all of us have experienced those cases, or sometimes they go into thysis. So oil gives you a lot of leeway in these bad cases, which have a steamy cornea with membranes in AC, exudates behind. But of course, for the classic end of, I would agree totally that we do core, we still do core. We still do a significant variety, which is oil, and we are quite happy using it.
Dr. Mahesh?
Yeah, I think it was a very balanced debate, and they both kind of agreed with each other about where you would use it. So a simple end of where you are pretty much able to see the fundus or just about the red glow is there. There's no need to use oil in an attached retina. But in the advanced endophthalmitis, where the vitreous is so thick and you know that you may be creating a break in the periphery, or it's a particularly virulent organism, is where you would probably use the oil. The argument is like Avinash himself is an co-author of one of the recent articles about silicone oil being like antimicrobial. But then he himself is speaking against it. So that was a kind of issue is here. So I would probably think, yes, silicone oil has a role. You would probably, some of us who were totally against using silicone oil probably will be using it in very difficult patients or patients who have an extreme kind of endophthalmitis. But the simple endophthalmitis will still go ahead without doing it, without using oil.
Thank you.
Thank you, Mahesh. And I think maybe just quick recap. Thanks everybody for a lively debate. Quick recap, I think Nitin will do just in 30 seconds, and I think yes, we'll close it. Let me thank everybody in advance. Thanks for being a part of things.
Overshot by 1 minute. Just a quick recap. The first 3 topics for medical retina. Dr. Mona has a good future in diplomatic as a diplomat in a career. So to be fair, the topics are like that. I think she agreed that there is a role of OCTA, there is a role of FFA ICGs in given cases. Monotherapy, as of now, probably no, but in future, we may be looking at if there is some newer drugs, newer medications. Cataract DME, again, there are situations where you would give it together, you would prefer to give it together, but there are situations where you would look at it giving separately also in that time. Dr. Mahesh covered up the other 3 topics where he spoke up about the 3D heads-up vitrectomy. He is not in favor of it right now, primarily from the cost factor, even though it has a lot of other advantages. Regarding ILM peeling, for and against, there are situations where you do, situations you do. He tilted towards doing more of ILM peeling, to basically from avoiding recurrent retinal detachments. And silicone oil injections in endophthalmitis patients has its role. In simple vitrectomies, you won't be doing oil injections. For more complex, as Dr. Manish has highlighted, cases where you're worried about the retinal status, you would consider doing it, injecting silicone oil. Dr. Pramod, last word.